So we're going to move to the spine here and talk about inflammation, ischemia, and infection. We tend to talk about these things in the brain, but they do all occur in the spine. And this is my first case, which I will show you as an unknown. You don't need to spend too much time looking at it. Obviously, there's a bright lesion in the spinal cord, and somebody decided the next best thing was to give some gadolinium, and there's a bit of faint enhancement. So at any rate, I'll give you a few of my own insights and biases right now. This is somebody with weakness and paresthesia, has a bright lesion in the spinal cord, and I don't think the gadolinium was terrifically useful. You look at a lesion like this, and you probably remember from residency, if you don't know what you're looking at, just go through the major categories. And, not obviously trauma or congenital. This is an adult, doesn't look like a vascular lesion, though you can have those in the spinal cord. It's not really expansile, particularly like a tumor. Might be an astrocytoma, could be some sort of odd infection. The sort of bacterial infections that Jim just talked about are quite rare in the spinal cord itself. You can have meningitis in the CSF space. You do have viral conditions in the cord, and I'll get into those later. Inflammation certainly seems to be up there on the list. And in fact, 70% of bright lesions you see in the spinal cord, taking all comers, are going to be multiple sclerosis. So if you say MS, if you had 70% odds in Las Vegas or the stock market, you wouldn't be working anymore. So we like to do better than 70%, but multiple sclerosis is certainly at the top of the list here. Sometimes they enhance, sometimes not. And so when you see this and you're just not sure, one of the things you need to think about a little bit is the internal architecture of the spinal cord. And the spinal cord is actually a mini brain, but it's sort of been turned inside out in the sense that the gray matter, which in the brain, with the exception of the basal ganglia, the gray matter is external, like the dark green bits of a broccoli or something like that. And the white matter is in the middle. The spinal cord, the white matter is on the outside, and the gray matter is on the inside in this sort of butterfly or goalpost, if you like, football configuration. And so where, if you have multiple sclerosis, which is a white matter disease, as we all know, it's a demyelinating disorder. You have to have myelin to demyelinate. It's going to be in the big white matter tracts, and those are principally the dorsal columns that govern proprioception in the midline and back, and the lateral columns, lateral spinothalamic tract out here, that have more to do with strength and motor function. And with good modern high-resolution CT scanners, particularly if the patient is able to stay still, you can start to see this internal architecture, and they're showing you on the diagram what you can define. And studies have been done showing that if the lesion is in the posterior columns, which govern vibration and position sense, this is somebody with a bad lesion in the posterior column, and it took a lot more vibrating stimulus of their feet for them to feel anything, but their strength was pretty okay because their lateral spinothalamic tract is okay. If the lesion is lateral, you're going to have good vibration sense, but you are going to have weakness. Now, I don't think this is how you're going to diagnose somebody having weakness or proprioception problems, but it just gives you a sense of where the white matter actually is. And I'm sure all of you have seen MS patients where you've said there's a lateral lesion or a dorsal lesion, and now you'll have a little better sense of why that is. Now, this is tumefactive multiple sclerosis. I picked the most giant lesions I could possibly find to embed this into you, which is if you don't know what you're looking at in the spine, be it some sort of leptomeningeal carcinomatosis or enhancement or masses. If you look at the brain, there's a whole lot more white matter and gray matter and leptomeningeal reflections in the brain than in the spine. So often the answer is as simple as looking at the brain, and here we see tumefactive MS. So the patient that I showed you originally, I'll give away the secret, was an MS patient. Now, when you're looking at the brain, you want to look very carefully because sometimes the MS findings are very subtle. You see the lesion only in the cord, and you might think this brain scan is negative, but if you look at the arrow here, this is a T2 coronal. There's bright signal in that optic nerve, and we just had a lecture about the visual pathways. Blurred monocular vision would probably be a symptom here. And one of the things occasionally is that the abnormality, particularly the enhancement, might not be in the easy part of the optic nerve to see. We all can see it within the orbit. It's a straight line. But when you get back into the optic canal towards the chiasm. It's a little bit trickier to see, although I think it's quite obvious here. I'll show you another case that was actually missed. And it looks like it's not the best images here to show you in terms of the GAD-FATSAT images, but you don't see too much on the axials, but as you sort of work your way back in the intracanalicular portion of the nerve, you can see that it's enhancing. There was something in the spine. And there is one variant, though, you need to know about, and that has been mentioned already. But as I said, when you do spine radiology, we all learned the three locations. A lesion is either intramedullary or it's extramedullary intradural, like a meningioma, or it's extradural, and this is the only way we think in this straitjacket. But think of the fourth location, the brain, because the answer might just be upstairs there. So this is what was mentioned already today, which is the neuromyelitis optica spectrum disorder. It used to be called Devick's disease. We're trying to get away from those eponyms. And it's in a patient who has optic neuritis, like that case I showed you, the second one, and you have myelitis. Why isn't it MS? It's a different lesion. There are these antibodies that can be picked out to aquaporin. They're quite sensitive and specific as things go in neurology. And the lesions in the spinal cord are much longer than the typical MS lesion, and you don't see the typical lesions in the brain at the callosal septal interface. And here is one of the neurology references. You can see this great big long lesion in the mid-spinal cord. And again, I think most of us wouldn't think of an astrocytoma here. It's much too long. It doesn't really look like MS, and you would want to look at the optic nerves and obviously get the serologic testing. And it's one of these things, like the spinal dural fistulas and the sagging brain, that once you know it's there, you start to see a case or two every year or two. And if you don't know it exists, you don't see any of them. Here is another case where, unless you know what it is and that it can be out there, you might just say, MS, dorsal columns, probably poor vibration sense. And indeed, this patient will have poor vibration sense and will be shuffling around and having a difficult time. But in fact, it's not multiple sclerosis. Look, it's going over 5-6 segments. That would be very unusual. Probably worth looking at the brain to make sure there's nothing going on there. And some of you may think of this as being related to vitamin B12. There's something combining problems, but this is nitrous oxide intoxication. And it is the same thing as another lesion that we all learned about, and I'll get to that in a moment. So what you may have learned about for your boards is something called subacute combined degeneration of the cord due to a vitamin deficiency B12. This can be due to malabsorption or poor diet and so on. In fact, this has been associated with people who have bariatric surgery because they take away so much of the stomach that they can't absorb certain vitamins. And it has this inverted V sign, a little bit different than the MS and much longer craniocaudal extension. But this looks exactly like the nitrous oxide intoxication, and how can you tell them apart? Well, the point is you don't have to tell them apart. It's the same disease because the mechanism has to do with nitrous oxide poisoning a coenzyme factor that has to do with conversion of one enzyme to another, and then once you oxidize it with the nitrous oxide, it's the same as if you didn't have the B12 in your diet. So it's a final common pathway. It doesn't matter if your rug is wet due to a leak in the roof or a leak on the floor from some plumbing. It's wet, you've got a problem, and you're going to have more and more of it. Interestingly, I've seen a number of these in younger people, and it has to do with an insidious little device, which is the nitrous oxide canister for whipping cream. And you may have seen these things around. And you know that spray whipped cream you get at the supermarket, and then you throw away the can, very wasteful. It's also pretty artificial, strange substance in there. You can take normal heavy cream, organic, from happy cows, put it in this little thing that looks like a coffee thermos, put in the nitrous oxide canister and blast it through, and you get instant beautiful whipped cream. So, great thing to have at your Thanksgiving dinner. And the problem is sometimes people abuse it. We used to think of laughing gas, nitrous oxide as the province of the dentists and that sort of thing. This is from the New York Post. Of course, everybody picks on San Francisco, sorry about that, which is where I live. And there you can see dangerous drivers in San Francisco using the whippets while they're driving. And, I can't say I've actually seen these people, but I have seen people who drive as if they were intoxicated. So at any rate, you may see these, and again, nitrous oxide, unfortunately, we're seeing more and more of this problem in the spinal cord. Luckily, it is self-limiting if you stop whatever caused it. So as I said, we talked about the white matter in the spinal cord, but now we need to address the gray matter, and that's the central goalposts or owl eyes or whatever you want to call it, the butterfly. And here is a lesion where the abnormality is within that central gray matter, and if you look at this and then look down lower, it is certainly the same area. So what could be doing this? And this, when I talk to the trainees, I usually get these blank stares. And I say, okay, let's do a little thought experiment here. You're looking at a brain and you're seeing increased signal in the gray matter, because this is gray matter, in the middle cerebral artery distribution, and a couple of days later it enhances a lot. What is it? Well, it's an MCA stroke. Obviously it's a stroke. Well, why is it more the gray matter than the white matter? Well, gray matter needs more oxygen. It's more sensitive to ischemia. Okay, all right, great. Keep that thought. Now, let's say, as we just heard, you're seeing high signal and enhancement, but it isn't a vascular distribution. It's got a bit of the temporal lobe, a bit of the frontal lobe, maybe going completely non-vascular. Well, what is it? So we've done that thought experiment. Here you see enhancement of these regions in the goalpost or butterfly. So here we have the stroke, middle cerebral artery distribution, enhancing. Nobody would have any difficulty with this diagnosis. And then the second one, I think similarly, is quite easy. It's encephalitis, a viral one, herpes. As how did it get there from the ganglia? We just don't know. But anyway, this is clearly herpes or some other virus in the temporal lobe. So all you have to do with that difficult gray matter case of the spinal cord is pretend the spinal cord is a miniature brain, which in a way it is, because it's just that you have the white matter on the outside and the gray matter on the inside, and then all of the behaviors of viruses and ischemia preferentially going after the gray matter, and multiple sclerosis preferentially going after the white matter. Your little inside-out brain is no longer a mystery. So here is a case just to reinforce this, and I'm giving it to you with a little bit of history. This is somebody who came in after one of those epidural spine injections, and they put in Marcaine with Kenalog, or whatever the recipes the pain specialists use. And that evening they came to the hospital having difficulty with their legs, numbness, difficulty with urination, and so on. And they got an MR. And you can see some high signal in the cord here, and it does have the butterfly pattern. Okay, so what happened? Well, this is a known and feared complication when they go higher up, that they get into one of the spinal arteries, and the artery of Adamkowitz, the principal artery supplying the lower cord, is usually around T12L1, but it can vary, and there are lumbar arteries that can supply. And when they do these epidurals, they're supposed to give a little puff of contrast to make sure they're not in a vessel. But if you've seen some of the fluoroscopes that they use to do these and the size of the patients, you're not exactly getting the best resolution angiography. And it's very rare. I mean, if you gave an experienced person the mission of cannulating percutaneously the artery of Adamkowitz, they couldn't do it in 1,000 tries. But you do it inadvertently, probably 1 in 1,000 times, and if you don't know it and you inject a particulate steroid, this is what you get. Luckily, this isn't a complete stroke, as with an occluded vessel. The vessel usually still works. It just, you put in some material. The Marcaine may give you some problems temporarily, and then the steroid particulates wear off, and this patient did have a nice recovery. So the point here is just to know what a spinal cord ischemic injury looks like, and this is one where we know exactly how it happened. And here's one that I showed you earlier. This is a patient who had massive aortic surgery, type A dissection. They had to replace the whole aorta, long pump time, and the spinal artery unfortunately suffered. So this is, we know it's ischemic and we know it's enhancing. So the same thing. Now, there are lesions in the spinal cord where you say, well, it's both white matter and gray matter. It all kind of looks fuzzy. And this is an example of that, somebody who's got tingling in their hands, weakness, and well, once again, let's do the brain experiment. If you have somebody who has white matter disease, and it's not really little lesions that you could count like multiple sclerosis, and it doesn't look like the Physicus type infarcts that spare the corpus callosum, but all the white matter has kind of a little bit of increased signal very diffusely, and maybe a little atrophy. Well, what could it possibly be? This is lupus myelitis, which is a small vessel vasculopathy and gives you small vessel ischemic changes, and that's exactly what you have here in the spinal cord. And this won't particularly get better with steroids the way, say, multiple sclerosis will, because it is ischemic damage. Now, what about other viruses? Fortunately, due to vaccination, we don't see much polio in the US, almost none now, but this is from a colleague overseas who showed us a case of what polio would look like if, God forbid, it returned. Very much that butterfly gray matter preferential pattern. This is an AIDS-related viral problem, and it actually does get the posterior columns as well as the gray matter. But as again, with antiretroviral therapy and so on, we see less and less of this. But this is the vacuolar myelopathy, also occurs in the brain. Now, with viruses, the one that's been in the news in the past few years is COVID, and this is a big article where they collected all the COVID cases that had neuroradiologic findings. And here you can see there are findings in the brain, and perhaps you've seen these in the literature, but the spinal cord always gets second fiddle to the brain, and you get similar findings in the spinal cord where it gets swollen, and you have increased signal on T2, sometimes enhancement. And the big question in the spinal cord, is this the virus itself, or is it something like ADEM, a reaction secondary to the virus by the immune system? I don't know that that's really knowable, but it's just something to put in the back of your head. If you see something like this and the patient has had a respiratory illness, and think of the COVID virus. And interestingly, it's not just the white and gray matter, but the nerves can be affected. Here you can see enhancement of all these various spinal nerves, and down in the lumbar region, you can get the cauda equina enhancing. So probably this is a reaction to the infection rather than the infection itself. We don't know for sure, but it is a transition point to something we do know more about, which is this syndrome, and I'll give this to you as a little bit of an unknown. This is a child, as you can probably tell by looking at the vertebra and discs, and they were 3 years old. They were, toddling very nicely, totally potty trained, and they went on a trip, and the child got ill and had diarrhea, and then all of a sudden couldn't walk and didn't have control of bowels and bladder. And what this is a Campylobacter infection. And you may think, well, that usually gives you diarrhea. How on earth could that affect the central nervous system? Well, it turns out that there are reactive antibodies, not the Campylobacter itself, but rather antibodies that then will give you this Guillain-Barré type symptom, and you can see the enhancement of the nerves and of the conus. So as we get into some of the inflammatory conditions, rheumatoid arthritis, we see obviously a lot more older patients these days as the baby boomers age. This is rheumatoid arthritis, and I'm sure you can see on that little blue line the atlantoaxial interval has increased. And one of the questions the neurosurgeons will have is, do they need to do some sort of fixation at C1-2, or is the problem really down here where there's osteophytes at C4, 5, 6, 7, like most of us, and how stable is this? You can get plain films, and what we do sometimes is flexion and extension in the MRI scanner, and here you can see that in fact there is impingement on the cord when you do flexion and extension. You want to be very careful. Don't ever push the patient beyond their comfort level. Do very, very fast imaging. But as you can see from this, the patient obviously needed surgery at C1-2, which is a lot more difficult than lower down in the cervical spine. Some sort of anterior cervical discectomy down here wouldn't have solved the problem. So rheumatoid arthritis. And there you can see the erosion of the dens. So we're all familiar with this. Here is another autoimmune disease, ankylosing spondylitis. We see it on plain films, and sometimes we're not sure if it's dish or ankylosing spondylitis. But when you have a very rigid spine, it's easy with comparatively minor trauma to fracture it. And this sort of fracture might actually be overlooked on a plain film of the thoracic and lumbar spine. You have the ribs in the way. Sometimes even the elbows are in the way. But if you pick up on this on a plain film, of course, I'm not showing you the plain film. This is a CT. You can see on the CT there's a fracture there probably of the anterior flowing osteophytes, but not super impressive. But what's impressive about this is if you look at the subsequent scans, is that you get bleeding sometimes. And as we know, so many people are on anticoagulation now, and particularly with the novel agents, it's felt to be safe, and a lot of people have atrial fibrillation, what have you, and are living older. So you want to catch these, because what can cause paralysis in this patient, even if the fracture looks pretty stable, is the epidural hematoma, and I've seen some cases like this. So you obviously want to be aware of this and image it in an aggressive fashion if there's any neurologic problem. Other things that can cause alterations in the vertebral column, radiation myelitis. We all know that the vertebra will get a fatty appearance, be bright on T1 after radiation, but the spinal cord can actually become bright and inflamed too. This is a radiation port. There's more and more care given to radiating the cord. But certainly, this is a child, actually. You can see, you might look at those vertebrae and say, is this Hunter's or Hurler's, or why are these vertebrae so peculiar? But they look perfectly normal in the thoracic spine. This is a child who had an astrocytoma, and growth arrest was caused by the radiation. So radiation is one of the causes of inflammation in the spine. And unfortunately, as patients move from state to state, clinic to clinic, you don't always have the old films or the continuity to know what's happening. You need to be a bit of a sleuth. And this is a patient who had head and neck cancer, and they were radiated. They also had sarcoid, and here you can see 6 months later, they're developing neurologic symptoms. The cord is getting bright, and they wait a little bit, and the brightness is going down. There's some enhancement, and the conclusion is this has to be some sort of cord tumor. After all, they had a tumor of the epiglottis, maybe it metastasized to the cord. But before we jump to that conclusion, how often do we see metastases to the spinal cord? And this is something I'd love to get Jim's input on, which is, let's say the brain is 100 times the volume of the spinal cord. I'm just sort of making that up. We should see 1/100th of the number of spinal cord mets that we see brain mets, but we don't. I've seen a couple of spinal cord mets in my life, and the ones you see are usually leptomeningeal CSF, but a met dead in the middle of the spinal cord, very rare. Maybe it has to do with the fact that all those spinal arteries come off at segments at right angles, and little emboli don't like to make right angle turns. I just don't know why, but this is the sort of thing, rather than thinking met to the spinal cord, you should think something else. They thought met to the spinal cord. They did a biopsy. Here you can see the post-biopsy film. The spinal cord is not a good organ to biopsy. With the brain, there's plasticity, you can have recruitment of other pathways. The spinal cord is a straight cable. Any injury, you're done. And what they found was coagulative necrosis. And so why was there so much edema when the enhancement is just in this little region? Well, this is a phenomenon that is not particularly appreciated. It's called the pre-searing state. It has to do when you have obstruction to CSF due to, it could be due to a disc, it could be even due to a Chiari malformation, whatever. All of a sudden, the CSF can't flow around the cord, so it flows through the cord. And an analogy in the brain, again coming with this brain-spine continuum, is think of a big blood clot from a basal ganglia that obstructs the aqueduct of Sylvius. What do? You get hydrocephalus. Where does all that CSF made by the choroid go? It weeps out through the ependymon. You get transependymal flow of CSF. This is the equivalent in the spinal cord flow through the cord itself, called the pre-searing state. And I'll show you a couple of examples later. Probably the most common thing we see in radiation in gynecologic tumors, these fractures of the sacrum, the Honda sign, and the main thing is just to avoid somebody thinking you ought to biopsy this, because these fractures have osteoclastic activity. They look like sarcomas. Obviously, they're not. They're extremely common. This is a study from Korea. Over half the patients had them who had gotten GYN radiation. So again, this is in the inflammatory gamut, we have to come up with things like what this is. And you see something in the spinal cord here, leptomeningeal tumor. We're not sure what it is, but astutely something here in the brain was noticed. The brain was imaged. The pituitary stalk is very large. As we remember that Satchmo differential for pituitary stalk lesions, one of the first things on it is sarcoid, and this is neurosarcoidosis. And again, getting the brain study was extremely helpful. And this obviously looks very different than a dural enhancement. This is leptomeningeal. So again, always consider that fourth location. Now, as we think about common things in the spine, here we see these two vertebral bodies that are abnormal, and I think most of you would realize this is some type of infection. But just to bear in mind, you can have lymphoma that looks like this, but usually lymphoma will not get to adjacent vertebral bodies or affect the discs. Whereas when you get this thickening of the longitudinal ligament for very long segments, it isn't bulky, and this adjacent disc disease, that's almost certainly going to be an infection. Now, one thing about infections is discitis is not the primary disease. The primary disease is osteomyelitis. It's usually hematogenous. What happens is you get spread from your teeth, your skin, wherever, and then it goes to the disc. This patient was a young athlete. They thought maybe a pars fracture. Of course, not a pars fracture on CT. There was thinking about doing a biopsy here, and we got an MR. One thing I do in MR is a lot of coronal planes for these paraspinous sorts of problems. We think of the ankle, the shoulder, we're doing all these oblique coronals to this ligament, that ligament. We're very unimaginative in the spine, sagittal, axial, and look how nicely this shows that you have erosion of the cartilaginous end plate, and this has cartilage on it, just like your knee does, any other thing. There's a little piece of cartilage here, and the bacteria have to eat their way through it to get into the disc, and then the disc is eroded very quickly. The psoas here is in fact bright. So this is the hallmark of osteomyelitis, early stage, and then eventually the disc will be affected, and then once the disc is affected, the next vertebra falls very quickly. This is a nice slide Dr. Cabal gave me that shows that the disc is essentially avascular in the adult, which is why we don't really heal our disc extrusions and fissures very well. And the arteries will seed bacteria here, and then they break through this little cartilage at the end of the vertebra. And once they're in the disc, ball game's over. It gets to the nest disc because the disc is kind of defenseless. And you go from this picture very rapidly to this, which is the discitis osteomyelitis complex. It's crossed, and I think nobody would have any difficulty with this because making the diagnosis of infection. And then it gets even worse. You can get epidural abscesses and cord compression as things progress. So the thing is to catch these things early. Sometimes you can get a pure epidural abscess that's seeded from elsewhere. There's thinking that Batson's plexus, venous plexus, if you're an old gent with prostate trouble, the bacteria can ascend and they won't be hematogenous. Hard to know where this came from, but again, this is an epidural abscess without a problem in the vertebra. And one of the big problems we run into, speaking of older gents, which some of us, or at least I'm becoming, is, and women, when you get back pain and you have something like this, is this just modic type 1, 2, or 3 changes from a disc wearing out, or is this an infection? And the white count might be a little elevated, lots of reasons that could be. And how do you tell the difference? I get asked to put needles into this all the time. And usually they say, well, we just gave the patient presumptive antibiotics, outpatient, but we want you to needle. What is the chance of my getting a yield on this after a week of outpatient antibiotics? Just about 0. What if they say the blood cultures are positive still? We want you to go in there and find out where it's coming from. Well, I get out this bloody pulp. It's a blood culture. Of course it's positive. You already told me it's positive. So there's actually a feeling that these disc aspirations are not so much the answer, although I love to ask for them. And here's a nice article by Dr. Tannenbaum in New York about the value of diffusion-weighted imaging. Just out of curiosity, how many of you are you doing diffusion-weighted imaging in the spine? They're not the prettiest images. I'll agree with that. But the concept here is with degenerative disease and infection, it's going to be dark on T1, it's going to be bright on T2, but on diffusion, it stays bright because, as we were just told, pus is bright on diffusion. But because there's no pus in the modic type generation, in fact, it's just sclerotic bone, you get this claw sign of where there's a little bit more cellular tissue at the margins. And this is the claw sign coined by Dr. Tannenbaum. And the concept, once again, is normal marrow. The water is fairly free. Once you get pus, there's a lot of restriction. And so here's the example I just showed you. And you see that claw sign. Okay, so this actually was negative for infection, didn't need a needle. And the claw. Here, another one. And nice example of the claw. And so, at any rate, this is the well-marginated linear finding that you can see in this article. And now what about, here is infection. So this is the claw, this is infection. You can see a lot of positivity on diffusion. And here, this is clearly infection. I don't think this is, as I said, the discitis osteomyelitis complex, showing how bright that is on the diffusion sequence. So I think this is something that's out there that as time goes by will be more and more of the equation and is sometimes a good way to stave off these aspirations, which I don't find terribly productive. So here is an example of such a case. And I'm just wondering, I'd like you to stare a bit. You don't have to do the audience response here. Is this infection, or are these modic type changes here? And you might say, well, the disc isn't that bad. It doesn't, the end plate edema here, maybe it's infection, but I can't say I'm super confident here. Does anybody see anything else that might tip their hand? All right, well, I'll show you the diffusion. What about up there? Anybody see that? Probably not. Anybody see it now on diffusion? It's a light bulb. So very much is in the brain and the spine continuum. Go with a light bulb. Diffusion really can help you out. So this was clearly infection, okay? And I tell you what, a lot easier to put a needle into this. You see it right here? I'm happy to put needles into this thing all day. There's nothing I can hurt. Could even do it under ultrasound. Putting a needle into a disc up here, yeah, you can do it. It's more work, though, and more dangerous. Okay, so not every infection will destroy the disc. Here you can see a disc-sparing infection that's going out into the psoas muscles, tuberculosis. And again, we don't luckily see that much. This is another tuberculosis case, which is pachymeningitis, thick, again, borrowing from the Greek, from Jim. And if this was H. flu or staph or strep, this patient would be devastated because the tuberculosis is not angioinvasive. The patients actually can survive, and this patient ended up doing well once they were successfully treated. And here is looks like a meningioma. It's actually a dural-based tuberculoma, and once the patient was treated, all this edema went away because of this pseudosyrinx. And here is an example of what the pseudosyrinx is, or the presyrinx. You see a Chiari 1? It was treated, and the edema and the syrinx went away. So this pre-syrinx state, sometimes you will see edema on the spinal cord from obstructed flow. And here's just a final example. You see something in the cord. Look at all this edema here. And sometimes the brain spine continuum, I say, do a transplant. Put that lesion in the brain. As we've learned, if it's got a dark rim, is bright on diffusion, enhances, it's probably an abscess. But I don't think most of us would really recognize that until you take it and transplant it into the brain, at which case we would call it an abscess. And in fact, this was an abscess, and this was treated, but it just shows you when you're in the spinal cord, you can get this edema, and that's that pre-syrinx business. So you can get the obstruction of CSF flow. If you don't know, put a needle in, but I think there's many reasons you can do it with MR, and there's how we put the needles in. And here's our final case. I hope you get it right. Weakness and paresthesia, solitary lesion. What's the best thing to do? We don't have our little Polev here, but I hope you would consider looking at the brain to find the other potential MS lesions.